Hello YouTube, welcome to Dr. Vibes A Learning Point. This is the part 2 of the infertility series. Part 1 has been uploaded, you can watch that. This is the part 2 of infertility video in which I will start with female infertility. So what can be the causes of female infertility? Just imagine the female reproductive tract, hold on to each part and then you can answer. So first you have ovaries, which can be a problem here. From ovaries arise the tube. The tube will lead to the uterus or the cervix, and then there's some other problems as well. Most commonly it is tubal or ovarian problems that can lead to the female infertility. Now, before taking up every cause, you must understand that what can be the basic pathology in either of these parts or organs. So, either there can be infection in this part or malignancy or some congenital defects which can lead to the infertility. So, in ovarian causes, what can happen? There can be hormonal problems like PCOS. The video of PCOS has been uploaded in the channel. You can go and watch that in details. Now, there can be premature ovarian failure. There can be radiation exposure. There can be endometrial cyst. And there can be luteal phase defect. So usually ovarian causes are related with the hormonal problem like PCOS, premature ovarian failure, like the chocolate cyst, the luteal phase defect. In tubal causes, there can be malignancies, there can be tubal surgeries, tubal infection that is called as salpingitis, there can be tubal adhesions, that is seen in case of endometriosis, and there is Cartagena syndrome in which the ciliary function of the fallopian tube is defected. In uterine causes, there can be fibroid, which is a benign mass found in the uterus. There can be Asherman syndrome, that is uterine syndicate, that means adhesions in the uterus. There can be chronic endometriosis, and there can be Mullerian abnormalities. So Mullerian abnormalities is a congenital problem. Asherman syndrome is adhesions, and fibroid is a kind of tumor. Now in cervical causes, there can be infection, which is called a cervicitis, and there can be anti-sperm antibodies in cervix. So if sperm enters through the cervix, there are some antibodies which will destroy the sperm, and that can cause infertility. Now come to the investigations. So you have to investigate the ovaries, you have to investigate the uterus tube, and you have to investigate the human semen to come to a conclusion that where lies the pathology of infertility. First, we will start with ovarian investigations. Now, there are some markers of ovulation which is very, very important to know. And these markers of ovulation are actually the indirect markers which can guide you to ovarian infertility. So if a woman is having regular cycle, if a woman is having mid-cycle ovarian pain, which is called as Mittel-Schmerz, if the woman is having premenstrual symptoms, if the woman is having primary spasmodic dysmenorrhea, this is usually seen in case of progesterone withdrawal. So these are certain of the symptoms or the history points that I am having premenstrual pain, I am having pain during the periods, I am having regular periods, etc. These are the points that yes, women is ovulating. Now in the signs, you have basal body temperature that rises around the mid-cycle. There are some cervical mucus changes that occurs before ovulation and after ovulation. The before ovulation cervical changes is due to estrogen. You will see that your cervical discharge becomes thin and copious. That is, that can be elicited by stretchable Spin-Barrett test. And after ovulation, you will see that your vaginal discharge has become thick and scanty, and that occurs due to the progesterone, and this is called as the Brett's test. So this is the stretchable Spin-Barrett test, and this is the Brett's test. Okay. Now you have the vaginal cytology that you can also do. This is also after ovulation and this is before ovulation. Now, we can also do urinary LH kits to check for the LH surge, and this occurs 2 days before the LH surge. So you can check the levels of LH in the mid-cycle, and a few days later you can check. So if there is LH surge, that is a sign that yes, the woman is ovulating. Now you have to check the serum progesterone level. If it is more than 5 nanogram per ml and it can go up to 20 nanogram per ml, that means ovulation is present. And finally, the indirect marker is endometrial biopsy, which is done on day 16 to look for secretory endometrium and subnuclear vacuolation. Okay, so these 1, 2, 3, 4, 5, 6 is your symptoms, and 7 is your basal body rise of temperature. So these 7 are the markers of ovulation. Okay, now what are the indirect ovarian investigations? You can do a laparoscopy where the corpus luteum will be present, and that will show a positive test that yes, the woman has been ovulating. And obviously USG can be done, which shows you 2 important things. This is a very, very important findings, that what is the USG marker that shows that a woman is ovulating. So there will be a ruptured follicle and there will be a triple line endometrium. And the conclusive point of ovarian investigations is pregnancy. Obviously, if the woman is pregnant, that means she has been ovulating, and that is why she is pregnant. Okay. Now, apart from this, there can be indicators of ovarian reserve. So if you have not got lost what I've been discussing, so we have been discussing what are the causes of infertility in women. We have taken up the ovaries first, and in ovaries we have seen what are the indirect, direct and conclusive markers of ovulation. And second, we have come to know about the ovarian reserve. मतलब अगर eggs or follicles अच्छे quantity में है ovary में, तभी तो वो ovulate करेंगे ना. So what are the markers Day 3 FSH, Day 3 estradiol. Yes, one student asked me what is the importance of Day 3. We take Day 3 because that gives us the baseline investigations. उसके बाद में estradiol और FSH और भी hormones के level बहुत इधर उधर होता है pregnant menstrual cycle में, इसलिए we take the baseline markers. We also have inhibin B. We have clomiphene citrate challenge test. You have anti-Mullerian hormone and you have anti-follicular count. And the best out of all these ovarian results is the anti-Mullerian hormone. This is a PG question, that how much anti-Mullerian hormone is considered poor and good. Less than 1 nanogram per ml is poor marker, and more than 1 nanogram per ml is a good marker of ovarian reserve. Now, last topic that we will discuss in this video is, consider that if a woman has ovarian problem. So how will you correct that to correct the infertility? So basically you can do ovulation induction. You can, and this is achieved by letrozole, and this is achieved by clomiphene citrate. The second thing that you can do is, और थर्ड थिंग इज गोनाडोट्रोपिन्स. सो बेसिकली हम लोगों को ओव्यूलेशन करवाना है विमेन में. आप लेट्रोजोल दे सकते हो, क्लोमिफिन सिट्रेट दे सकते हो, आप गोनाडोट्रोपिन्स दे सकते हो. आई विल मेक अ डिटेल्ड वीडियो अबाउट ovulation induction, so you can go and watch that. Here I'm just discussing the headings. The second thing that you can do is follicular monitoring. So this comes under the management of ovaries problem that can lead to infertility. In the next video, we will discuss about the tubal investigations that can lead to infertility and how to correct those tubal investigations.